Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is treatment failure and switch to second-line ART in children with HIV. And the speaker is Dr. E. Suresh. Dr. E. Suresh, sir, is associated with the ART Center at the Pediatric Center of Excellence, Institute of Child Health and Hospital for Children since 2006, and is currently working as a senior medical officer. He has completed Principles of HIV STD Research course from the University of Washington, Seattle, and postgraduate diploma in HIV medicine from the School of Tropical Medicine, Kolkata. We welcome you, sir, for today's session and request you to start the session.
Good afternoon, one and all. My topic is about the treatment failure and switch to second-line ART in children with HIV. The objectives of this session is the treatment response in CLHIV, how to identify the treatment failure children, how to give step-up adherence counseling in CLHIV, what is the second-line regimen in children available in the NACO program, how to identify the second-line ART failure, what are the drugs available in the third-line ART. So the topic is treatment failure and switch to second-line ART in children living with HIV/AIDS. What are the challenges is the unusually high baseline viral load, the intrauterine and perinatal exposure to ARVs like nevirapine, and the child having an immature and developing immune system. And the main problem is the dependency on caregiver for adherence support, the dynamic dosing with the periodical increase in the weight, and the non-availability of child-friendly formulations. There is a treatment failure in CLHIV despite optimal adherence to the drug as like 100%. So it is mainly due to accumulation of drug-resistant mutations resulting from unusually high replication rate of HIV virus, and there is a error-prone reverse transcriptase enzyme, and there is a naturally due to selective pressure from drugs or from the immune system. These are the causes for the treatment failure in CLHIV who is adhered to the drug more than 100%. So the pharmacological options for second-line ART in children are limited due to the non-availability of pediatric formulations of many ARVs, and there is a perinatal exposure to certain ARV drugs. So the importance is to support and promote the factors that facilitate and sustain the response to the first-line ART regimen as long as possible. So how will you monitor the treatment response to the first-line ART? There is three main headings. One is the virological response, second one is the immunological response, third one is the clinical response. How will you how will you monitor the virological response to the ART? Viral load should be done every 6 months after initiation of ART. That should be less than 1,000 copies per ml. In HIV-infected infants and young children with high baseline plasma viral load, it may take longer than 6 months. Then comes the immunological response. Increase of 50 to 100 cells per millimeter cube within 6 to 12 months of initiation of ART in older children above 5 years of age. It may be higher in younger children. Clinical response. The child should be asymptomatic, free from the infections, and there should be a weight gain in 12 to 24 weeks. Clinical monitoring should be done at every visit and should include anthropometric evaluation, general well-being, neurocognitive developmental assessment, and the adverse reaction to drugs and the drug interactions and features of high risk. So the treatment response not merely depend upon one It depends upon the three main headings: virus, CD4 count improvement, and the clinical response to ART. Clinical and immunological reactions. The clinical and immunological features of suspected treatment failure among CLHIV who are on first-line ART for at least 6 months. New OIs, recurrence, or clinical events after 6 months of ART after ruling out iris, failure to thrive or weight loss, and there is a developmental regression or delay, and the progressive decline in CD4 counts or increment lesser than severe immunosuppression level over 6 to 12 months. These are the features, silent features we have to suspect treatment failure. So what is the definitions in treatment failure? The loss of antiviral efficacy and triggers the switch of the entire first line regimen to the second line or behind, suspected by immunological and or clinical indicators, but needs the confirmation of unsuppressed viral load. The second line ART is the next regimen used in sequence immediately after the failure of the first line therapy. Before identifying treatment failure, certain factors like duration of ART should be more than 6 months, new OIs or iris should be ruled out, and the treatment adherence should be considered. How to identify treatment failure? When to switch to second line CLHIV? The child should have received the regimen for at least 6 months. And the adherence to the therapy should be optimal, that is greater than 95%, and treated and resolved any active opportunistic infections before interrupting CD4 counts, because there is any new opportunistic infections or active opportunistic infections, there is a chance of decrease in the CD4 count, and the iris immune reconstitution inflammatory syndrome must be excluded, and the primary malnutrition should be ruled out. It could be the cause for the failure to thrive, and there is a weight loss also, and the adverse effects of drugs manifesting like treatment failure should be ruled out. All suspected clinical and immunological treatment failure should be confirmed by virological criteria for treatment failure. Then after consulting SACEP at pCoE, COE or ART plus center only, we have to switch to second line regimen to CLHIVs. So, as I already mentioned, that virological failure, the 2 consecutive HIV-1 plasma viral load values of greater than 1,000 copies per ml with the following criteria. After 6 months of ART initiation, after giving 3 months of step-up adherence counseling, and adherence in each of last 3 months was 95%. So when the 2 consecutive viral load more than 100 copies per ml after 6 months of ART initiation, and the adherence should be greater than 95%, and giving 3 consecutive sessions of step-up adherence counseling. When coming to the immunological failure, it's separated into 3 different main categories: 12 to 35 months, 36 to 59 months, and the children aged 5 years and above considered to be like the adults. Whereas in 12 to 35 months, CD4 percentage falls below 15%, and the persistent CD4 levels below 200 cells per millimeter cube after 12 months of ART. Children between 3 months and 5 months to 5 years, the CD4 percentage falls below 10%, and the persistent CD4 levels below 200 cells per millimeter cube. When children aged 5 years and above, fall of CD4 count to pre-therapy level, 50% fall from peak on treatment level, and persistent CD4 levels below 200 cells per millimeter cube after 12 months of ART therapy. So clinical failure is new or recurrent WHS stage 4 after at least 6 months of ART, and there is a progressive neurodevelopmental deterioration, and there is a growth failure. See, regarding the immunological failure, so it differs depend upon the. So in case of 12 months to 36 months, if the percentage, CD4 percentage falls below 15%, and there is a persistent CD4 levels below 200 after 12 months of ART. Whereas in case of 3, instead of 15%, 10%, and the persistent CD4 below 200 cells per million.
Participants are requested to kindly bear with us. Sir will join us shortly. Kiran sir, please make pCoE ICH the co-host. Sir, can you please try to share your screen again? Visible?
Full mode screen is visible, ma'am.
No, it's not visible in full screen, but otherwise it is visible.
So there should be minimum 3 sessions in the step-up adherence counseling, and all the counseling sessions should be done by the same counselor. Both caregiver and the child should be counseled together and individually in all sessions. Counselor need to review all the barriers that led to poor adherence and provide customized counseling. And a customized adherence plan should be developed with involvement of both the caregiver and the child. And there should be ensure weight documentation in white card and green book on each visit, and check if the correct dose is given as per the weight band. CAC to be involved in the counseling and supporting the caregiver, and the child should help them achieve regular adherence. Group counseling should be taken up for tailoring support for children in different age groups. To allay fear of side effects of ARV, assurance should be given to the caregiver and the child that they will be taken care of at the ART center if reported in time. Assessment of mental health of the caregiver and the child, a timely referral for appropriate management. So there are 5 assessments, 5 A's of treatment adherence. One is the problem, effects on individual and family, probable consequence. Assess the problem, assist in addressing the barrier or planning what and when and how to do. Advice, importance of adherence should be advised, and arrange necessary referrals, both medical, psychological, and follow-up sessions and admission in ward. Agree treatment adherence plan and plan to address the barrier. These are the 5 A's of treatment adherence. General counseling measures in step-up adherence counseling. Child-centric counseling is recommended. Building rapport with CLHIV is very important. Involve child in all decisions along with her. Probe for palatability issues related to ARVs, if any, suggest solutions. Check the pill swallowing capacity of the child. These are the main importance: palatability, the pill swallowing thing, and involve child in all decisions along with the caregiver. The child should be counseled for taking all the pills prescribed with emphasis on benefits of ART. Ensure that the ART timing does not clash with the child's school and other extracurricular activities. Suggest reminders if not used. Encourage proper nutrition. It is very important, and increase the activity. Probe for any barriers to adherence. Then what is for the caregivers? Ensure the caregiver has adequate finance to travel to ART center along with the child for his or its HIV care and treatment. If required, try to link to the existing welfare schemes, NGOs for financial support. Issue of long distance travel can be addressed by linking them to the nearest facility for HIV care and ART pill pickup. Caregivers should be counseled for age-appropriate disclosure of status to the child, if not already done. Counselor or the medical officer to support in the process if required by the caregiver. Counselors to ensure that ART is given under direct observation of a responsible caregiver. Ensure about that frequency, number of pills, and timings of ART. And ensure that the ART timing does not clash with the caregiver's work timings. And timings of child's food and other activities. Suggest reminders for pill intake if not using any. Ensure the weight documentation in white card and green book. Proper nutrition support. In case of double orphans, ensure that the extended family provides basic care and psychological support to the child. Session 1 of Step Up Adherence Counseling. Just after receiving the viral load results, plasma viral load is greater than or equal to 1000 copies per ml. Check the child's treatment adherence to have a baseline adherence. Involve CAC to counsel and support the caregiver and the child in achieving required adherence. General counseling along with the customized counseling to be done based on the identified issues. So, to try to build a rapport with the CLHIV, explain the benefits of ART in age-appropriate words. Assess the barriers leading to poor adherence. Motivate to take medicines in the prescribed dose with full adherence and suggest reminders. Ensure documentation of weight at each visit in white card and green book. Ensure that the child is receiving appropriate ART dose as per the weight. Assess for OA or any co-infection and refer for appropriate management. Assess mental health for adverse effects of the drugs and nutrition status. Regarding the caregivers, review caregivers' understanding of adherence and pill intake and viral load suppression, and assess 5 years of treatment adherence, and check ARV medicines given to the CLHIV, what, when, and how, and who are giving. Inquire about pill intake frequency, timing, and regularity. Check if reminders are being used. Then discuss the risk of treatment failure due to non-adherence, motivate for age-appropriate disclosure of status, assess mental health, and develop an adherence plan. Sessions 2. 1 month after previous session, that is a second session, second step of adherence counseling, review child adherence between first and second sessions, general counseling and reassessment of any new barriers, check if the previous barriers are addressed and solved, involve CSC to counsel and support the caregiver and child in achieving required adherence. So, if child achieved greater than 95%, praise and reward for it, and encourage them to continue the effort, and reassess the child's understanding of importance and benefits of ART, remotivate to make medicines regularly, and reassess the mental health and assess for any new barriers. And discuss any new barriers in adherence, and remotivate age-appropriate disclosure of status to child to the caregivers, re-emphasizes the importance of directly observing taking of ART by the child and the reminders, modify the adherence plan, and assess the mental health of caregiver and refer for appropriate management. Adherence improved to 95%. Appreciate the efforts made. Usually 1 month after the second session, third step of adherence counseling to be done. When adherence is greater than 95% in last 3 consecutive months, plan a plasma viral load test. Explain to the caregiver to keep plasma viral load report appointment and return for viral load report, praise the caregiver and CLHIV, and motivate to maintain adherence. Plan further sessions with caregiver and child. Involve CSC to counsel and support the caregiver and the child in achieving the required adherence. Counseling measures in third session of step-up adherence counseling. If adherence improved to greater than 95%, praise and reward the child if adherence is greater than 95%, encourage, remotivate, and re-emphasize. Same thing applies to the caregivers also. Appreciate, encourage, and re-emphasize the direct supervision and significance of the adherence. If adherence is not improved, reassess the child's understanding of importance, remotivate, and rule out opportunistic infections or co-infections, reassess mental health and refer for appropriate management, assess for barriers of pre-existing and new. And for caregivers, discuss the risk of treatment failure, look for barriers, reassess 5 A's, and give a customized counseling, modify adherence plan, and motivate for disclosure. If plasma viral load is less than 1,000 copies per ml, appreciate both caregiver and CLHIV. Advise to continue the same regimen, re-emphasize adherence, involve CSC and plasma viral load as per guidelines. So if a viral load is less than 1,000 copies per ml, conduct viral load count at scheduled duration. Viral load is greater than 1,000 copies per ml. Counselor to provide a step-up adherence package to the patient for 3 months. Is adherence in the last 3 months greater than 95%? Yes, means you do the to be continuing same regimen. What are the second line regimen in CLHIV? So the definition is the first line ART is the initial regimen prescribed for ART in children as soon as HIV infection is diagnosed. Second line ART is the subsequent regimen used in sequence immediately after the first line therapy has failed. What are the points to note before switching? We have to see there is any cross resistance exists between the zidovudine and stavudine, and there is a high level of zidovudine stavudine resistance, reduce the susceptibility to abacavir. Compromised by multiple nucleoside analog mutations NAMs, but TDF tenofovir often retains activity against the nucleoside resistant viral strains. Tenofovir and abacavir may facilitate evaluation of the K65R drug resistant mutations, which mediates resistance to non-zidovudine NRTase. Usually, there is a complete resistance in NNRTase. NNRTase single exposure to children through infant air prophylaxis can result in archived non-nucleoside reverse transcriptase. inhibitor resistant mutations. So what are the steps to be followed for review by SACEP for suspected treatment failure? First is step 1, define treatment failure. Define treatment failure by virological testing. See if adherence to treatment is adequate, counsel and support. SACEP will see this and take decision on providing second line ART. Decide on NRTA component of the second line regimen. Select NRTA backbone as per table 3.5.7. Decide on third component of the second line regimen. Patient education and agreement on treatment plan, including follow-up and monitoring. So, what are the second line ART regimen in children? If the child is on pseudovidin, lamivudine, lopinavir, ritonavir, and the age is less than 6 years, and the weight is less than 20 kg, the dolutegravir is ruled out. Then there is no change in the regimen. If child has advanced disease stage, then after consultation with the pCoE or COE or pediatric experts, shift to abacavir, lamivudine, nevirapine or efavirenz. So ALN or ALE. So normally age less than 6 years and weight is less than 20 kg, the treatment failure is less probability. We have to assess for the adherence. If the child may be having a stage 4 disease or advanced disease, with the consultation with the pCoE, COE, you can consider shift to ALN or ALE. The age is between 6 years and 10 years, and the weight between 20 and 30 kg. Instead of nevirapine or efavirenz, you can go for dolutegravir. If the age is greater than 10 years and the weight is greater than equal to 30 kg, you can go for tenofovir, lamivudine, dolutegravir. If the child is on abacavir, lamivudine, lopinavir, ritonavir, if the age is less than 6 years and the weight is less than 20 kg, only in case of advanced disease, instead of abacavir, you can go for pseudovidin. Instead of lopinavir, ritonavir, you can go for nevirapine or efavirenz with the backbone of lamivudine. In case of hemoglobin is less than 9 grams per deciliter, continue the same regimen. Once the hemoglobin status improved, you can go for ZLN or ZLE. If the child is age is 6 to 10 years, the weight is 20 to 30 kg, you can go for pseudovidin, lamivudine, dolutegravir. If the hemoglobin is less than 9 grams, then continue the same regimen and change to ZLD. If the child is on pseudovidin, lamivudine, efavirenz, you can think of abacavir, lamivudine plus lopinavir, ritonavir. When the child crosses 26 years of age and weight greater than 10 kg, you can go for TDH dairyman. In case of age and weight is 20 to 30 kg, you can go for abacavir, lamivudine, dolutegravir. In case of weight is greater than 10 years, you can go for tenofovir, lamivudine, dolutegravir. So only in the case of abacavir, lamivudine plus lopinavir, ritonavir, the age of greater than 10 years, 30 kg, TLD is not applicable. So if the regimen is ALE, and you can go for pseudovidin, lamivudine plus lopinavir, ritonavir. If the hemoglobin is greater than or equal to 9 grams per deciliter, till pediatric DTG formulations are available in the market. If the hemoglobin is less than 9, continue the same regimen till anemia is corrected, then change to ZL, lopinavir, ritonavir. Whenever the child crosses the 6 years and weight is greater than 20 kg, child can be transitioned to DTG based regimen. If the child is aged to and 6 to A child age between 6 and 10 years and weight between 20 to 30 kg. Instead of abacavir, zidovudine, instead of efavirenz, you can have for dolutegravir if hemoglobin greater than 9 grams per deciliter. Or else DTG plus lopinavir plus recycled non-zidovudine plus based NRTI backbone. So in case of ALD failure, you can go for ZL lopinavir. In case of TLD failure, you can go for ZL plus lopinavir. Second line ART options for children exposed to multiple NRTs. So what the current failing regimen is tenofovir, abacavir based regimen, and the third drug is pCoE. So previous exposed drug is zidovudine, stavudine. CD4 count was not suggestive of immunological failure, and at the time of substitution from zidovudine to and weight is less than 10 kg, no change in regimen unless in case of advanced physical and clinical disease progression. Switching to second line regimen, nevirapine based regimen with zidovudine re-challenge under close hematological monitoring. In case of 3 and 6 years, ZLE, age between 6 and 10 years and weight between 20 and 30 kg, re-challenge zidovudine if current hemoglobin is greater than 9 grams per deciliter. You can consider zidovudine 3TC and DTG. Tenofovir, abacavir based regimen, and third drug is pCoE means previous exposed drugs zidovudine or stavudine. Age less than 3 years means you can continue ZLN if hemoglobin is greater than 9 grams per deciliter. If age between 3 and 6 years and weight between 10 and 20 kg and no change in the regimen till the anemia is corrected, then change to ZLE. Age between 6 and 10 years and weight between 20 to 30 kg. This effectively moves the child into third line ART regimen. Hence, adherence should be carefully monitored and supported. So, earlier we see the third drug is pCoE. Here the third drug is NNRTI. Previous exposure to drug is zidovudine, stavudine. In age less than 3 years and 10 kg, no change in regimen is recommended unless in case of advanced disease clinical progression. Age between 3 and 6 years and weight between 10 and 20 kg, ZL plus lopinavir. Age between 6 and 10 years and weight between 20 to 30 kg, re-challenge zidovudine if current hemoglobin is greater than 9 grams per deciliter. Reappears after re-challenge dolutegravir plus lopinavir plus recycled. So first line failure with history of multiple NRT exposure. CD4 count was suggestive of immunological failure at time of substitution from zidovudine to abacavir, tenofovir. No change in regimen is recommended unless in case of advanced disease progression. In between, if the age crosses 6 years, you can consider dolutegravir plus lopinavir plus recycled non-zidovudine based NRTI backbone. This effectively moves the child into third line ART regimen. Hence, adherence should be carefully monitored and supported. So, in case of HIV TB co-infected children, what is the second line regimen, ART regimen? In case of DTG based regimen, double the dose of DTG. The dolutegravir available dose is the 50 milligram. You have to give twice daily. If the patient has rifampicin based regimen. In case if the patient is taking lopinavir ritonavir based regimen, super boosting of lopinavir with ritonavir. Normally it is 1:4. It should be 1:1. Adherence based regimen means there should be no modification is required. In case of DTG plus lopinavir ritonavir regimen, double the dose of DTG and also the ritonavir lopinavir should be given in the combination of 1:1. So DTG based regimen means twice the dose. Lopinavir ritonavir based regimen means 1:1 ratio combination instead of 4:1. So adherence means there is no modification. Initiation of second-line ART and anti-TB treatment in the presence of pCoE infection. Child being identified with the first-line ART failure, presenting with tuberculosis simultaneously. Anti-TB treatment initiation is priority. Second-line ART regimen should be started as soon as possible within 2 weeks of initiation of an anti-TB regimen. If the child is already on second-line ART regimen and develops TB, means you have to give appropriate anti-TB treatment and the ART regimen should be modified simultaneously. So initiation of second-line ART and anti-TB treatment in the presence of pCoE infection. Already on 2-HRZE plus 4-HRE treatment, PTG based second-line ART is to be initiated, continue, and DTG you have to give twice daily. If the patient is on the PI based regimen, means continue the lopinavir based regimen and super boost it. Need to initiate second line ART with the concurrent reduction, means you have to give 2 weeks anti-TB treatment, then start second line ART. Patient is already on second line ART and then detected to have TB co-infection, means initiate rifampicin containing anti-TB regimen or priority, modify the second line ART. What are the tests you have to do in monitoring part of the second line ART? You have to do hemoglobin CBC at the time of starting ART, then 1, 3, 6, 12, 18, 24. Then you have to do complete LFT, RFT, random blood sugar, and lipid profile. Random blood sugar and lipid profile have to be repeated once in 6 months, once in a year. Then monitoring patients on second line ART, viral load is baseline viral load, then 6 months, 12 months, 18 months, 24 months. CD4 also a baseline 6 months, 12 months, 18 months, and 24 months. Second line ART failure and third line ART. So what are the major reasons for second line ART failure among CLHIV? Same thing, the poor adherence and using modified adult formulations due to non-availability of appropriate pediatric formulations, late switching to second line ART, and all CLHIV and second line ART need to undergo viral load testing every 6 months. In case of adults, we have to do once in a year, whereas in children, you can do every 6 months. So third line ART regimens in CLHIV, age less than 6 years and weight is 10 kg, and the failing second line regimen is abacavir lamivudine plus lopinavir ritonavir, zidovudine lamivudine plus lopinavir ritonavir, stavudine lamivudine lopinavir ritonavir, ALN, SLN, ZLN. So if the child is less than 6 years and 10 kg, failure of this second line regimen is continue the second line with emphasis on adherence to ART. However, it is better to continue a PI-based failing regimen than NNRT-based one because of high genetic barrier of lopinavir ritonavir as compared to nevirapine and efavirenz. The age is greater than 6 to 10 years, the body weight is greater than 20 to 30 kg, and the patient is failed to ALD, ZLD, DTG plus lopinavir ritonavir. You can recommend a DTG BD plus lopinavir ritonavir plus existing NRTA backbone. age greater than 30 years and body weight 30 kg, failure in BD plus locomotor plus existing NRT backbone. So, what are the laboratory monitoring is the investigations to be done is first baseline, then 1 month, 3 months, 6 months. Then LFT is baseline, 3 months, 6 months. Renal function, 3 months, 6 months. Blood sugar, lipid profile, viral load, and CD4 count. The next session is on the 14th. Thank you.
Thank you so much,
Thank you.
sir. Any questions from the participants? Participants can now unmute themselves so they can even write their questions in the chat box. Any questions from the participants? Would anybody like to ask any question on this topic? Treatment failure? So I don't think there are any questions. Thank you so much for facilitating this session. Participants to kindly note that the next session will be held on 14th March, that's Tuesday from 2 p.m. to 3 p.m. The topic is nutritional care of HIV infected children and counseling for children and adolescents living with HIV. You can refer to chapter number 3.6 and 3.7 of the National Guidelines for HIV care and treatment for the same. The feedback poll is now visible on your screen. There are 4 questions in all. Please scroll through all the 4 questions and answer them. Requesting all the participants to please attempt the feedback poll. Thank you to all the participants for patient listening. We'll conclude this session now. Thank you, sir.